Good morning, everyone. And today I'll be presenting the title, or rather discuss the work on senescence in end-stage liver disease and its relevance in cancer and what the clinical relevance of this is. So basically, the discussion will be based on three questions. Why it is important to know the cellular fates, especially in liver disease. And in the cellular fates, we'll discuss about the hepatocyte senescence and to an extent cholangiocyte senescence, and how it is relevant in chronic, which is the data from ILBS, and also with acute liver failure from other people's data. And then how it impacts the cancer. And finally, the question, is it possible to rejuvenate a failing liver by a senescence-centric approach? So that means, can you target the senescent cell? So here I'll introduce two concepts on xenomorphs and senolytics. So before I go to define the terminology of the senescence, it's important to know what the cellular fates are. And for this, we need to revisit the cell cycle. And in a normal homeostasis, most of the adult cells, they exist in the quiescent state, or the G0. And whenever there is a need to divide, for instance, the stem cells have to divide, they actually enter into the cell cycle. And there are these gatekeepers, which are also called as the checkpoints, not to be confused with the checkpoints of the immunotherapy. This is the checkpoints of the cell cycle, which decides whether the cell can enter into the DNA or the S synthetic phase, the G2M, and finally it divides. So in a normal homeostasis, most of the cells are in a quiescent, including that of the adult hepatocytes, which are poised at a quiescence. However, either in an injury or in a hepatectomy donor, the cells enter from this G0 phase, and this is that means they are reversibly arrested, and now the gates open up. The gates are within the cells, not outside the cells, and the cell enters into the S phase, G2N, and then they divide. So this is a normal homeostasis, and again the cell goes back into the quiescent mode. However, if this degeneration or the injury persists in chronicity, then these gates actually close up very badly, and the cell is not able to enter into the next phase of the S phase, which is the DNA synthesis. The reason for this is that the cell has accumulated so much of a damage that evolution has decided it's better to catch these culprits here rather than releasing a damaged cell into the proliferation. So for a definition of the senescence, it's actually a state of permanent growth arrest. Unlike a quiescence which can enter into the cell cycle, the senescent cells cannot enter into the cell cycle. So the question is, what causes this growth arrest, or what causes this the fate of senescence? So basically, broadly, there are two mechanisms. One is a telomere dependent, the other two are actually telomere independent. So with each round of division, the cells, the chromosomes, or the end of the chromosomes or the chromatin material, the telomeres, they start to shorten. And when they shorten enough, there is a crisis in the cell, and it's better that a shortened telomere cell is actually detrimental. So the cells enter into this arrest mode. The telomere independent pathways are by oxidative stress and mitochondrial DNA damage, and whatever be the mechanisms, they all meet at this checkpoint, and these checkpoints are P16, P53, and P21. So these are actually the guardians of the cell, and when they get activated, the cells undergoes a permanent arrest. Now the permanent arrest is what is called as the senescence. Now why this slide is important is, all these molecules, P16, P53, P23, they are actually mutated in cancer. So hence there is actually a nexus between senescence and cancer. Now just coming to very briefly, if you have to look at the overview of a liver equation, when you are talking in terms of a failure, it's actually parenchymal exhaustion. And I also learned in ILBS something called as a parenchymal extinction. So when you say the exhaustion is, the cells are present but they are not dividing, and that's what we wanted to ask, whether it is a state of senescence or not. The parenchymal extinction is actually death. So combined, these two leads to a complete regenerative failure, and the reason is can you actually rejuvenate this failing liver? So one you can do that by two tricks. Either you rejuvenate a senescent cell, or you actually prevent the cell death, and there are clinical trials going on with caspase inhibitors. Now, this is all at the level of the cell, but why it is important from a clinical perspective? It is important for the following reason. The senescence actually translates at the level of the tissue dysfunction, and in the recent times we heard a lot on the inflammatory changes, the sarcopenia, frailty, and when they all add up together with the metabolic disturbances, these leads to frailty or the aging. So at the level of cell, you will call cellular senescence. You will not call it as a cell aging, or so the better word is senescence. At the organism level, it is frailty and aging. So hence there is again a connection, because with the aging population is the one which is also much more vulnerable to cancer. So now we come to the discussion on why it is relevant to understand senescence in liver disease. And I'll show some of the data in a very brief format. And this was mostly with the chronic liver disease done together with the pathologist. So now if you look at this cirrhotic liver, they have these, so usually it is called as a regenerating nodules. But even though it is called as a regenerating nodules, this is actually a failure. The cells do not permanently divide. So the question that we asked is this in the regenerating nodules, are the cells dividing, or they are actually going into a regenerative failure? So the question to us was to how to identify hepatosenescence in an in vivo or in a liver tissue. So the gold standard is actually to use beta-galactosidase lysozymal staining, but for this we always require a fresh tissue. So what we did was, using an in vitro based approach and also using a microbe based approach, these were our previous work, we identify a set of 5 markers, of which the most robust in the liver happens to be the P21. And P21, as I showed you in the previous slide, is actually a gatekeeper, which actually, when it closes, the cells do enter into a permanent regenerative failure. And the cells are also Ki67 negative or PCNA negative and cyclin WD1. So we used a battery of these markers, and as you can see, these are the low power and the high power images. And here in a cirrhotic liver, almost 70 to 80% of the hepatocytes are their nuclei are positively stained for these P21, indicating that these are non-dividing cells. Now, so what we did was we developed kind of a senescence score, where now we are characterizing the senescence in the liver tissue using a DNA damage marker gamma H2X, the gatekeepers, checkpoint inhibitor, which are P53 and P21. And also what we think is that our data indicated that the nuclei starts to lose their membrane, nuclear membrane, indicating that it is also a case of laminopathy or a nucleopathy with respect to the liver disease. So all this work is published, and what we had done is we used different etiologies of HCV, cryptogenic, and the best turned out to be in the fatty liver, and in the fatty liver, the hepatocyte senescence is a prominent. So you can see here an enlarged view, all these black, the brown nuclei are actually P21. Now this kind of a cell is actually called as a ballooned cell, and in the earlier days, this was called as a zombie cell or an undead cell, mostly described by Anna Maidiels, and this is actually a senescent cell, and this I will describe later as we proceed. So what we found was that as you go from the normal to the decompensated cirrhosis, there is an accumulation of all these markers, and the only limitation in our study, and a big limitation in our study, was we did not do any clinical outcome, because our main at that time idea was to have the mechanistic part revealed and also to find whether we can actually detect these senescent cells or not. So this was all in a chronic liver disease. What about in acute liver failure? And this is a work from Stuart Forbes' group, and as a clinician, you can understand it much better. This is an acute fulminant hepatic liver failure due to acetaminophen injury. And within a week from the jaundice to encephalopathy, this patient underwent a transplant. So when the explant liver was taken, you can see that this is a P21 staining. And if you can appreciate, this staining looks similar to what I showed you in the biopsies from ILBS. So our work, so this work was published in 2018. By that time, we also had the similar results. But we did not do any outcome, which was a limitation. So since this was all in the adult liver, we thought we'll collaborate with the pediatric group and ask whether we can actually see the so-called cellular senescence on an aged cell in a pediatric population. So you would expect why in a pediatric population this should come up. So this is work done by Kalpana Panda for her DM thesis, and what she found was this here she actually could correlate with the outcome of the disease. So this is a survivor biopsy a post-mortem biopsy, and you can see the intensity of the P21 is much more higher in the post-mortem, and in the explant liver, almost 90 to 100% of the cells are senescent. So with a few samples which she had, she could very nicely show the outcome using this as a marker. So now again coming back, as cellular fate is very important, the question is which of these cell types are actually undergoing the process of a growth arrest. So these are all the cell types which are there in the liver, and mostly what we find is that the hepatocytes, mostly it undergoes a fate of cell death in ALF, which is the liver failure. However, in the chronic cases, it can also, most of them, it actually, the regenerative failure is actually because they are in a permanent growth arrest. So is the case with the LSECs, which actually lose their fenestrae. The cholangiocytes also undergo, and I'll show you some ILBS data. We do not know about these immune cells, and what we think is that there is also an immune senescence occurring, which we are now trying to figure it out with Dr. Nirupma's group. So now I'll come to this part, the cholangiocytes, because this is one thing, but I'm not going to show any data on this, but what is actually considered. So we always think senescence is bad, but if it is bad, why did evolution keep it? So it has been shown that senescence is actually good when it appears in a context of a stellate cell. So if a senescence occurs, this is actually leading to the process of wound healing. So I'm not going all the data, I'll show only with the cholangiocyte senescence. And this is a work that we did where we showed that the biliary epithelial senescence, this was work from Dr. Archana, where she could actually correlate it with the cellular rejection. So in the allograft biopsy, if you use all these three markers and develop a senescence score, you will find that this actually leads to a poor prognosis, especially in the early chronic rejection. The other thing that we see, especially with the cholangiocytes, is in the biliary atresia. And in the biliary atresia, what we think, this data is still unpublished, we think that the senescence of these epithelials, biliary epithelial cells, can be a cause of ductopenia or biliopathy. So this is still under work. So briefly summarizing till now, a senescent cell is permanently growth arrested. It incurs a lot of genomic changes, and the extent of the senescence may dictate the outcome, but we need more data to do it, at least from an ILBS perspective. But there are now a lot of literature with respect to senescence in chronic kidney disease, pulmonary fibrosis, etc. So now coming to the second part, this was still the chronic liver disease. So now the question is how it impacts cancer. So before I go into the cancer part, I want to introduce a paradox here. So the regenerative paradox is, on one hand, you have the loss of function, and here the loss of function is exhaustion of the cells, leading to a regenerative failure. So if the cells are not dividing, in this background, the cancer develops. So now the question is, if this dividing cell can be put back into so-called senescent kind of a phenotype, it will be non-dividing and it will be good. Now this is a kind of a provocative statement, but in general, what is believed is that the non-dividing senescent hepatocytes are actually an anti-tumorigenic mechanism. And this has been done especially with lung cancer, where they find that in pre-neoplasia, if there is a senescent cell, it is actually good. The outcome is actually good, because the senescent cells, as I'll show in the later slides, is inflammatory, and it helps to clear the cancer cell. So this is a very provocative paper which I found in Trends in Cancer, where it says cirrhosis is a questionable risk factor for hepatocellular carcinoma. You as a clinician may disagree, because most of the cancers occur in a cirrhotic background, but it is a food for thought. And it has been seen that chemotherapy can also induce senescence. So in an evolutionary context, what has been noted, that senescence, if it is occurring in a very early stage, it is actually good. As I said, with stellate cell senescence, it's actually good for wound healing. In a short-term basis, it is tumor suppressor. But it is a long-term consequence. If it keeps sitting there, that's when the problems start, and it can do two things. It can lead towards cancer, and it can also cause tissue aging, leading to frailty. So what we asked the question was, we find till here that in cirrhosis there is an accumulation. So we thought, like when we were going through with this literature, we thought that in a cancer setup, we should not find any senescent cell. And what we found was, there were occasionally, so in this state, up till cirrhosis, we will find like 70 to 80% of the cells are actually in a growth arrested state, leading to regenerative failure. But in a highly dividing environment, like an HCC, which is a Ki67 positive, you find 5 to 10% of the cells still lingering around. So the question was, from a basic biology, what is the relevance of the senescent cell in this in a cancer context, and can it modulate the tumor microenvironment? The reason we asked this was again based on our work, where we had earlier shown that senescent hepatocytes are highly inflammatory in nature. So we think that inflammation is only caused it is happening only in the immune compartment. But it has been shown very nicely that liver is actually an immune organ, and the parenchymal cells, which constitute 85 to 95% of it, they can also secrete a lot of these cytokines and chemokines, which we could show the moment the cell enter into a senescent mode. Moreover, what we found that these senescent cells also have high amount of CXCR4 and CCL. So that means they have chemokines and chemokine receptor. This indicated that these can attract the immune cells towards them. So what we did was we did a very simple work where we made the cells into a senescent mode. So these are all in vitro work, and we collected the secretome, leaving behind the cells, only collecting the secretome, and then we treated the monocytes from healthy individuals and asked the question whether these secretome can change the fate or polarize these macrophages. And to cut the story short, what we found was the moment the senescent secretome is put with the monocytes, we get high CD163 and 206 cells, indicating that these are actually the M2. So this work was done together with Dr. Nirupama, and what we reported is that these M2 macrophages are actually anti-inflammatory, and they are also tumor promoting. But as I said, all this work was in vitro. We do not know the biological consequences, but what we think is, if there is a senescent cell in a cirrhotic background next to a cancer present, maybe it is driving the tumor towards a cold. So the extent of senescence in a cancer has to be determined. However, this is all in vitro data that we have right now. The next thing what we did was we asked whether the secretome can modulate the neutrophil. So we were only interested with the innate immune components. So now that we took the secretome and put it together with the neutrophils. Now the typical function of a neutrophil is actually to phagocytose. But in some instances, what happens is that the nucleophil burst out and they release out all their chromatin, and with the chromatin comes out the myeloperoxidase. And what it forms is called as a neutrophil extracellular traps. And what we discovered was the secretome of a senescent cell induces the net formation. But what we do not know yet is, if this is happening from a hepatoma cell, can this lead to a portal vein thrombosis? Because these nets are actually very fertile ground to attract all the platelets and actually make a thrombi. So these are all, so our limitations was all in vitro. While we could actually show with Dr. Archana the presence of the M2 macrophages in the HCC, but this needs to be studied further with respect to nets. So now coming to the last part of it, targeting. So we till now know that these are important for regenerative failure, the presence of the senescent cells. But the question is, can you target these senescent cells and rescue or rebuild the liver from undergoing a regenerative failure? So I'll very quickly show the data, and for that, I have to put it first in a cartoon format. So now, let's say you have this series of events from cirrhotic to cancer. There is an accumulation. So how do you rebuild the liver here? There are many ways, and in ILBS, they are doing mesenchymal stem cell therapy. Then you can also do a cellular therapy, and of course, organ transplant is the last option. So what you can do is at least think, can we delay this process? So when you can delay this process with certain agents, that is delaying senescence or rejuvenating the cell and suppressing this inflammation, the terminology is called xenomorphs. And I will show you quick data, where we can do this. Even better than this approach is get rid of all these senescent cells. So when you get rid of all these senescent cells, you have the normal cells there. These have the potency now to regenerate. And this is where the future medicine is going on with the concept of senolytics. So the lytics is getting rid of this. That means eliminating the senescent cell. And the third and most challenging is just revert back these senescent cell into a normal cell. And this is a challenging thing. And I will not go into this part. I'll show you the data, and also I'll show you one slide where it is important in terms of organ transplant. So I'm showing, I'll skip this data. So what we found was the senescent cells, when we take the cells which are oxidatively stressed, and then we did a simple electron microscopy, we find that there was a degeneration of the mitochondria. Now this was in the in vitro. So what we did was we took the explant tissues and we did, so these are images from the explant tissues where we did the transmission electron microscope, and you can see these petite and long and good mitochondria in the healthy side and with a lot of cristae. But these cristae are absent. You can hardly make out these mitochondria here. So if you see, this is a ballooned mitochondria, the ones with the red. So the question was that what is happening to these? So that means the senescent cell have a damaged mitochondria, and is it possible to revive this mitochondria? So when we went back into the literature, we saw that there is a process which is called as a mitochondrial unfolded protein response, or UPR-MITO. So what happens is that whenever there is a damage in the mitochondria, there's actually inter-organelle talk. So the mitochondria tells the nucleus, you come and rescue me. And it sends out a message through a battery of these proteins, of which one of the most important is this mitochondrial protein called the proteases, casinolytic peptidases. So what we did was, since in our readout, both in the tissues of the explants as well as in the in vitro system, we found that this protein was actually getting subdued in case of the senescence. So what we did was we cloned this gene, we introduced it into the cells and asked, can we revert or can we delay the senescence? And indeed we found that when we overexpress this CLIP-P, this is a mitochondrial protein. So you can see all these yellow dots showing that it is localized. So we now have a stable cell line, and if you now treat it with hydrogen peroxide or with palmitate, you will find that the oxidative stress is less, there's less of inflammation, and there is an improved oxygen consumption. So this indicated that although we could not reverse the senescence, senescence is actually inevitable, aging is inevitable, but if you can have delayed or do it in a healthy way, this is one example of a peptidase as a xenomorph. I'll first go back and show you again this fatty liver. Now this fatty liver, where you have these fat deposited, the giant cells, and these are the nuclei pushed to the edge, these are all P21 positive. Now there's another cell if you see here, these were actually described by Anna Maidel as zombie cells, undead cells, which were not doing anything, but they were also not getting eliminated like a cell death. So these cells we think, including this we think is a state of senescence. So what we did was we again took an in vitro approach and we treated the cells, the hepatocytes both, especially the immortalized hepatocytes, with palmitic acid. And this is a saturated fatty acid. And we found that the cell loaded with this palmitic acid is ballooned. It looks something like the end-dead cell. And this is also highly inflammatory. So we went back and asked the question, is the mitochondrial unfolded protein response defective now? We did find. What we also uncovered in this work was, they were in the mitochondria, and especially, so we did the total cellular pool, we found that the NAD levels were going two-folded down, and so was it happening in the NASH cirrhosis. Now why this is important? The NAD which is present is actually helping to maintain the redox, and also it as a cofactor for many of the enzymes. So what we uncovered was that in a palmitate-induced senescent-like state, the NAD level is going down, and this is because the circadian rhythm is totally disrupted. And this data I had shown in a previous slide where it is known already in the cirrhotics that there is a sleep disturbance. So we tried to put 2 and 2 in an in vitro based. And what we found is that the enzyme NAMPT is getting down-regulated and its activity is going down, leading to lower NAD. So the question is, can you supplement these cells with an NAD and see whether the mitochondria gets rejuvenated and the cell is back to work? So for this, we made use of nicotinamide riboside. Now this is something like vitamin B3. Now vitamin B3, the bioavailability is low, and this has been tinkered to make a riboside molecule, and here the bioavailability to get it converted to NAD is more. So what we could do is when you treat, so if you pre-treat the cells, and then you treat it with the palmitic acid, you can actually delay, you can stop the inflammation, and you can kind of rescue the cell, but you cannot completely reverse it back to normal. So that means it's kind of going towards an healthy aging, but the cells are working fine. Now why I'm showing this data here is, there is an interesting data which has come from the canonic group, and this is the EASL group, where they have found that in the ACLF condition, the tryptophan kynurenine pathway is actually hampered. What they did not show in this paper is what is the level of the NAD. So now is it possible that in a case of liver failure, whatever is happening, and there's a lot of data from Dr. Anupam as well, that there's a mitochondrial deflect happening. So can you use a xenomorphs either in the form of a mitochondrial peptidase or in the form of a food supplement like vitamin B3 and revive that? As again I'm saying, our limitations was we limited ourselves with the in vitro work because we were more interested in the mechanistic part. So I showed you, so now to get rid of the senescent cell, one is a xenomorph. That means you delay and get rid of the inflammation, which at least will give the so-called golden window period. The other is, and even better approach is, just get rid of these senescent cells. And this is a new area coming up, which is senolytics. So what is a senolytic? Senolytics are, so what people have found is, that the senescent cell, as I showed in the fatty liver, they just sit there and they do not actually die. So is it possible to elicit in these so-called zombie cells, can you actually make them undergo death so that you can eliminate them? So using repurposing, there are now first and second generation drugs which are there in the preclinical trials, and what they all do is they actually activate this molecule which is B-cell lymphoma, BCL2. And the BCL2 family is actually a pro-apoptotic. So what you can do is if you treat them with something like dastanib or navitoclax, which are actually in the clinic, these cells can be actually very selectively killed out. So now the most potent of all this, and which is the literature is filled with, dastanib together with quercetin. And what they are both doing is they're all feeding back finally into the mitochondria. So the way to get the liver built up is through the mitochondria. And what Dr. Anupam's group has shown is you take the mesenchymal stem cells, and these mesenchymal stem cells will actually give out their good mitochondria to at least the macrophages. So using these senolytics, there's a lot of preclinical trials going on, just not in liver. Liver, the data is very less. In osteoarthritis, so as I said, accumulation of senescent cell is leading to frailty, leading to aging. So can you get rid of these senescent cells in the bone, in the skin, in the pulmonary fibrosis? There are papers even in Lancet. And most importantly, in kidney injury. And I will show you one data with the liver organ transplant. So this is a very interesting work. So what is known in the literature is, whenever there, so the title of this is again from the Edinburgh group of Dr. Stuart Forbes. The title of this paper is Senolytic Treatment Preserves the Biliary Regenerative Capacity Lost Through Cellular Senescence During Cold Storage. So what is known that during cold storage, there is some defects occurring in the donor liver, and this can actually lead later in the life, in the recipient, these, you know this term much better, non-anastomotic strictures or the biliary strictures. And biliary strictures later in the life of an allograft can actually lead to increased morbidity. And using a preclinical model, what this group showed was that cold storage actually leads to more of a cholangiocyte senescence. And when the cholangiocytes don't divide, these leads to bad biliary strictures. So if you can get rid of these zombie cells again, through the senolytic pathway. So one is xenomorph, the other is senolytic. So you clear these cholangiocytes. The biliary strictures are maintained well. So all this work again done using an animal model and an in vitro, but in the end of the study, they have done using 3 donor grafts. So this you can understand it much better, especially the surgeons here. So they took the segments 2 and 3, and they did a normothermic perfusion with the preservatives which you have, and into that they added these 2 compounds. So the compounds which they added were these 2, dastanib and quercetin, and also this small molecule which can actually lead to senolysis. So with this, they found that post-treatment, so what they did was they perfused this liver for 2 to 3 hours, and then they took a biopsy specimen, and they found that this biliary strictures are maintained well. And in the same post-treated senolytic, they have done at the senescent cholangiocyte apoptosis, and that's what you want. You are going to eliminate this. They found that they are highly tunnel positive. But at the same time, the normal cholangiocytes, which have not undergone the permanent growth arrest, they start dividing. So are the hepatocytes. Although this is only a marginal increase, but this gives like a ray at a light at the end of the tunnel. So what this paper from Stuart Forbes group says is that senolytic treatment may be efficacious as an intervention before the liver transplant and preserving the organ structure, especially from biliary. So now I'm just coming towards the end of my this thing. So there are two other things which are happening during the chronic liver disease. One is a kidney injury. The other, which we heard a lot, was the sarcopenia and frailty. And there are a lot of papers now where they're showing that chronic kidney disease is actually due to both senescence in the tubular epithelium as well as in the podocytes. And here again, using preclinical model, it has been shown that the senolytics can be a good hope. And a similar study has come up in Lancet with lung fibrosis. And this is a paper from Dasarathi where they have shown that in liver, during sarcopenia, the ammonia which is released from the liver is actually leading to senescence or regenerative failure of the muscles. So sarcopenia is nothing but a skeletal injury and a muscle cell senescence. And this is the only paper which says that you remove the ammonia, you can actually revert back, as I showed you in the previous slide, you can actually revert back the skeletal muscles to a normal. So can something like that be done in the liver is a question. So coming to the conclusion, so what we now know is that senescence is so it is very important to know the cellular fate. I only covered the regenerative failure because of growth arrest. Cell death is also very important. The accumulation of the cell, the senescent cell, can cause premature aging of the liver. And there are reports available that if a person is obese, he is 33 years old, his BMI goes up to 33, from 23 is the normal. So every 10 units of BMI increase is actually going to age. So can we say that there's actually a premature aging of the liver? So a 33-year-old fatty liver, chronological age is 33, but that of the liver is actually, you have to add at least 3 to 4 more years to it. So the age of the liver turns out to be 36. We've shown that the senescent cells are inflammatory, and so the meta-inflammation could be due to this. This is leading to regenerative failure, and targeting approach to be a new promising. So there are many challenges and things to be done in future. One is correlating these markers with the outcome. We need to have a detailed outcome on the secretome. Actually, everything that right now, if you have to detect the senescence, you need to have the tissue. But can we have something in the circulatory markers? Immune aging is one of the hot areas now. And the other is how the microbes are actually causing this. So the microbes also age, and the aged microbes can also lead to an organ dysfunction. So finally, I would like to thank so much of the work were done by the graduate students, Bijoy and Savera, who moved out. And I could do some work with the pediatric groups with Kalpana and Dr. Neha. And I thank all the ILBS team for helping me to move from an in vitro to more towards a clinical scenario. Thank you so much.